Hello and welcome to the Cardiovascular System Cardiac Conduction lecture. There's a few slides I'd like to share with you this morning on the structures found within the heart that lead to conducting electrical activity and how we can monitor that electrical activity using something called an EKG. We know that regulation and circulation of blood is very important. Many organs need to perfuse blood to supply them with nutrients and oxygen specifically. And we have what's called the cardiac cycle, okay? This cycle is responsible for regulating the amount of blood and the force of blood being moved through vessels, okay? We know those factors, these things that create changes within our physiology, such as exercise, changes in pulmonary function, the amount of nutrients, the amount of oxygen and carbon dioxide that's found in the blood, and a variety of other things, really dictates the rate and force which we move blood. To get started on how the heart and the cardiac cycle works, one of the first things will be introduced is this structure called the SA node. And we'll see in a minute, this is a piece of tissue found in the heart, specifically on the right atrium. This is innervated by the central nervous system, okay, CNS. If we stimulate the central nervous system using sympathetic stimulation, there's a hormone called norepinephrine, okay, that provides an excitatory response. It increases the rate and depth that heart is going to contract and to move blood. Conversely, the parasympathetic stimulation, which is typically our rest and recovery phase, can release another molecule, a neurotransmitter in this case called acetylcholine, which has an inhibitory effect. And between these two and a few other mechanisms we'll look at in a minute, we can upregulate or downregulate the cardiac cycle to meet those needs and to respond to those changes to maintain homeostasis. One of the first things we need to understand in this conduction system is specifically that the heart responds to electrical input, specifically from the structure called the SA node. Okay, and we know that the heart tissue does a very good job at conducting impulses. Okay, so this SA node, sometimes referred to as the pacemaker, will set a rhythm, generate this 2-second impulse, 3-second relaxation period for an average of about 70 beats per minute for most individuals. There is a series of tissues that then carry that impulse throughout the heart to coordinate the contraction of the heart so that it's rhythmic in nature. We will show you in a moment some of these other structures. After the SA node, the next piece of tissue that would come into place is called this atrial sanctum. And these are a series of fibers that spread across the atria and provide this unified mechanism to contract the atria. It's very important that the atria contract first in unison, followed by the ventricles second in unison to effectively move blood. As we move from the atrial sanctum, and I'll show you a picture in a moment of all these tissues and how they are found within the heart, we know that they come together at this point called the AV node, the atrioventricular node. They rejoin and they form what's called junctional fibers, okay, to bridge that junction, if you will, between the atria and the ventricles. These junctional fibers form long strands through the septum on both the right and left side of the heart, and we call these branches, okay, bundle branches of the atrioventricular bundle. And then finally, at the end, those branch out on both the right and left side, forming Purkinje fibers, and those are the fibers that transmit that electrical impulse to the cardiomyocytes so that we can have a very syncopated ventricular contraction. Okay, atria first, ventricle second, lumped up in that order. Anytime we have a disruption of this cardiac conduction system, that leads to arrhythmia. These arrhythmias can play a role in diagnosing certain heart diseases. Usually the heart is beating either too fast or too slow or dysregulated in some fashion. It's not circulating blood very well. So oftentimes something like a myocardial infarction or a heart attack, those cells that make up the cardiac conduction system, they're impacted by lack of blood flow due to maybe plaque buildup or some kind of issue with blood vessels, and the heart is not being perfused with blood, and those cells start to die. And if those cells are dying, the fibers can't transmit electrical impulses through them, and this may cause an arrhythmia. So here's where we put all these together. If you see, we'll start number 1 with the SA node here. Okay, there's your pacemaker. Then you have your atrial synctum, which are these fibers that spread across both the right and left atria. Okay, they meet again in the junction or in the septum called the AV bundle, and you have your right and left bundle branches. Okay, here's your septum in the middle here, and then they branch off to form Purkinje fibers. Those are going to innervate the muscles of the heart deep in the myocardial tissue to cause those muscles to contract. Now, once we have an understanding of the cardiac conduction system and the tissues that make up the heart that allow those impulses to travel through the heart and generate an impulse, we can track those impulses through something called an electrocardiogram or an EKG. Sometimes called an ECG. K is Greek for cardio, so sometimes called an ECG. Electrocardiogram is a recording of the electrical changes that occur during one cardiac cycle. We can break that recording down into a number of different components, talking about where that electrical impulse is traveling through the heart, okay, and what this impulse looks like on a graph over time, okay? And I'm going to show you that graph in a moment. And there's some characters to the graph, and we'll be labeling characters. Shortly, there's a review activity following this where we're going to be labeling parts of an EKG and identifying those characteristic waveforms. First one we would see would be this one here, which is your P wave right here. The P wave is signified by the depolarization of the atria. That's when the electrical activity is presented across the atria and shows up as a change in amplitude on a graph, and we can detect that. The second one, QRS, follows a P wave, corresponds to the depolarization of the ventricles. So in the P wave, we have depolarization of the atria contracting first, and followed by the QRS, where we have depolarization of the ventricles. The ventricles are contracting second. Finally, a T wave here represents repolarization of the ventricles or recharging. That tissue needs to repolarize before it can then depolarize again. I'm going to add one more here. Let's use a different color. I'm going to add an additional structure here, number 5, the refractory wave. It's not really a wave, we'll use little r. That's a period of rest for the heart. The heart will not beat again, go through another cardiac cycle without that period of rest. Now, that period of rest could be very shortened, as we see an increase in heart rate, maybe due to exercise, but there's always a period of rest. This refractory also prevents tetanus or tetanic contractions that occur in other types of skeletal muscle. We would never see that in an EKG or in heart tissue because we always need to have that refractory period, that rest period, so the ventricles and atria can recharge and get ready for the next contraction. Now here on this diagram is what we refer to as a recording of an EKG. We notice that on the bottom is time, and on the left-hand scale, on the Y scale, is changes in electrical activity in millivolts. Our 0 mark is right here. Obviously, if we had no electrical activity in the heart, we would have a completely flat line. There'd be no changes in electrical activity. That's typically a sign of clinical death. We see some waveforms here. First, let me use a different color here. Let's pick red. We see our P wave, which indicates, if you remember from the previous slide, the atrial depolarization. Then we have the QRS here, which is ventricular depolarization. Notice a much larger in amplitude. If you remember from our fetal pig dissection, the atrial walls are very thin, so when they discharge electricity, it's a very small change in amplitude versus the ventricle tissue is much thicker, and we would see a greater change in electrical activity. followed by the T wave, which is electrical recovery or recharging of the ventricle tissue, and then the refractory period here. I added that little rest period. One of the things that appears to be missing is that recharge following discharge of the atrium. Normally it would follow or fall right here, but notice the QRS is sort of overshadowing this. This is called lead 2 for an EKG. When we do an EKG, typically in a clinical setting, there's 10 wires, and it's sometimes referred to as a 12-lead EKG. There's 12 graphs. This is only one of those 12, sometimes called the rhythm lead, or lead 2. If we wanted to see that hidden P wave or other components of the heart, we would have to use some of the other graphs that are involved. For this class, we're only going to be concerned with lead 2. So we're going to practice labeling some of these characters on an EKG, and you'll be doing that in an activity later this week. I'll start somewhere in the middle here. First, we label this as our P, that little bump. Then we have our Q, R, S, our T wave, and then the refractory period, followed by another P, Q, R, S, T, refractory, and that repeats over time. The important part of an EKG and understanding why this is important is at that time interval. Okay, the amount of time that these certain waveforms take and where they occur. There's a pattern, P, Q, R, S, T, refractory, and it repeats itself. And it happens at a certain interval of time. And we can learn a lot about the normal function of the heart and what happens in pathology looking at an EKG. If you remember from the previous slide, we mentioned that in our EKG, we're concerned with lead 2. Now, in class, we would normally run an EKG as a sample using limb leads. We would put the electrodes on the upper extremities, upper and lower extremities, arm and the ankle. And what we see is the right arm on the left side there, the left arm, and the left leg, typically by the ankle. We try to put those electrodes somewhere where there's not a lot of skeletal muscle, because that can show up as artifact. It can interfere with the recording. And oftentimes the person is pronated, they're laying down. We want to just be detecting those changes in electrical activity of the heart and not picking up any artifact or any interference from other devices or skeletal muscle. If you notice those 3 leads, lead 2 is measuring from the negative to the positive. So when we look at a deflection, this is a deflection that we would see in an EKG. A positive deflection indicates that the movement of electricity is going towards the positive electrode here. Or a negative deflection here would indicate the electrical activity is traveling away from the positive lead. And you can see here as electrical activity passes from point A to point B, we get this characteristic sinus wave, and that shows up as a rhythm on an EKG. As we mentioned on the previous slide, the time intervals are really important in determining if there's any issues or problems or arrhythmias that we had mentioned. You see in the top left graph here, a normal EKG is actually printed on what's called thermal paper, and you have these this red grid. And we know that these boxes represent a certain length of time. Each small box is 0.04 seconds. And then we have 1, 2, 3, 4, 5 boxes that make up a larger box. Each one is 0.2 seconds. So if we have a tracing of an EKG, we can quickly assess the time intervals for each one of those waveforms. Oftentimes, there are some very significant time intervals. For example, this P to R interval right here indicates the length of the P wave. Another important interval is the QRS interval, which begins just as that electrical activity is making its way down to this point of the Q, top of the Q, and then the bottom of the S. Another really important wave interval is the QT, where it begins from the Q and ends at the T. And we could also look at the R to R interval. That represents one cardiac cycle. So a typical heartbeat would last from any one point in the cardiac cycle to the corresponding point in the next cardiac cycle. We typically use the R spike, if you will. That's really easy to read on an EKG. It's a very defined point on that, and we can use that information to determine someone's heart rate. Now, if we're going to assume a very simple example, okay, to determine someone's heart rate from an EKG, we would look at the R to R interval. If the R to R interval is 1 second, okay, and we know that there's 60 seconds per minute, okay, we know that person has a heart rate of 60 beats per minute, and that's a really easy way to determine someone's heart rate from an EKG. Following this activity this week, you're going to be given an EKG with some sample rhythm strips, and using the information from the presentation, be able to label the waveforms, and be able to determine some of those time intervals and determine is this EKG normal or abnormal in some respect. Thanks for listening. Have a great day.